Hello, this is Lindsay Luther again. This is part 2 of our Women's Health lecture, and this section is going to focus on fertility, contraception, and preconception planning. I am going to try to keep this one to no more than 15 to 20 minutes. I really want to just give you some of the big picture considerations and help you to develop critical thinking in this area. And then the content that's in the lecture is something that you can go over on your own time to fill in the gaps in your knowledge that you already have. So let's start by discussing fertility. The purpose of this discussion is to help you to understand fertility concepts so that you can apply them to whatever the patient's goals may be, whether that is obtaining a pregnancy or preventing a pregnancy. In the last lecture, we did discuss the menstrual cycle. I want you to make sure that you fully understand this picture before we go forward. It will actually be pretty challenging to understand contraception and also to understand conception if you don't understand the way that these different hormones are working. Again, remember that the variability in the cycle length typically comes from that follicular phase, so the first half of the cycle before ovulation. But there is a little bit of variation in either side. Some women do have a little bit of a longer or shorter luteal phase as well, and that collectively contributes to the length of the cycle. So this slide talks about the fertile window. We can monitor fertility for either the purpose of helping a woman conceive a pregnancy or also avoid a pregnancy. There's actually a very short window in which a woman can become pregnant. Most women think that like anytime they can have sex unprotected, they get pregnant, and especially with teenagers, it somehow seems to always work out to be just the right time when they have unprotected sex, but really that is not true. There are only about 5 to 6 days a month when a woman can become pregnant. Those are the 5 days prior to ovulation and the 1 day after ovulation occurs, and that's represented by this pink area here. The reasons why these are the only days it's possible are because sperm can survive in the body for about 5 days, but the egg only stays in the fallopian tube where conception occurs for about 12 to 24 hours. So if the sperm is deposited anytime within this 5-day period, it should theoretically still be in the present in the fallopian tube to fertilize the egg when the egg is released. Because it takes the egg about 24 hours to get out of the fallopian tube, as long as there's still some sperm in the vicinity during this area, there's a possibility of pregnancy. This understanding of the fertile window is the basis of natural family planning or ethical family planning or the calendar method of preventing a pregnancy. These methods require an understanding of the woman's individual cycle, and there are some options for how to monitor that and to determine what the woman's individual cycle is. If a woman has unprotected sex during that fertile window with a virile partner, chances of pregnancy are approximately 10 to 30% for each individual cycle. Okay, so there's a number of ways we can monitor fertility. As we discussed briefly in the previous presentation, basal body temperature is another way of monitoring fertility that also considers the physiologic responses of the woman's body to those hormones and ovulation. So we know that the basal body temperature will rise by about 0.4 to 0.8 degrees after ovulation, and it stays higher until just before menses, which right here is day 28, so day 28 in this woman is probably the same as day 1 of the next cycle. So that temperature elevation suggests that ovulation occurred sometime in the prior 2 to 3 days. So if a woman charts her basal body temperature every day, she can predict when ovulation has occurred. There are some very important things about this. You need the right kind of thermometer that has enough decimal places, and you also need to take your temperature at the same time every day while lying still in bed after being in bed for at least 3 hours, and that means that you need to keep this by the bedside, set an alarm, and take your temperature. Fertility can also be monitored by keeping an eye on the texture of the cervix and the texture of the opening of the cervical os, as well as by the consistency and texture of the cervical mucus. This will change as stated on the slide as the body prepares for ovulation. And then There are also ovulation predictor kits, which are really monitors of the LH surge. They are urine tests in which you dip the urine similar to a pregnancy test. And you usually take them for 5 to 6 days prior to the expected time of ovulation. And then when you get a positive LH surge, that 24 to 36 hour period afterward is really the best time to have that 24 hours before that window. The next 1 to 2 days is the best time to have sex if you're trying to get pregnant. However, ovulation predictor kits that monitor an LH will not help you to avoid pregnancy, because it's possible that if sperm is already in the area for 5 days before that LH surge, that there will be a conception that occurs. Okay, so those are some of the fertility monitors that are available. There are actually others, and you might look into some of those in more detail. So I want to just hit a couple key points on contraception. First thing is that there are a lot of types of contraception, and they vary as far as whether they're temporary, permanent, implanted, injected, oral, whether they're non-hormonal or hormonal, or if they provide a barrier against the sperm meeting the egg. Most methods will not provide any protection against sexually transmitted infection. If you combine multiple compatible methods, you can reduce the risk of pregnancy. So for example, condoms and oral contraceptives together reduce the risk of pregnancy very much. However, if you were to combine a female and a male condom, that could actually increase the risk of pregnancy because they are not compatible. So when you're thinking about the different types of contraception and what you're going to recommend for your patients, you should be focused in on the whether, so you need to understand efficacy versus effectiveness. So this is whether the patient, how likely the patient is to get pregnant in that first year if they do 100% perfect correct use. And then there's an effectiveness rate, which is the typical use pattern of a woman. How many women are going to get pregnant unintentionally during that first year with this method? If no contraceptive method is used, the typical healthy woman has an 85% chance of getting pregnant each year. So all of these methods that we're going to talk about are better odds than that, but they do not all have comparable effectiveness or efficacy to one another. Some other things that you need to consider are that different methods will be more or less convenient, expensive, reversible in terms of long-term coverage versus short-term coverage, will offer varying degrees of sexually transmitted infection protection, may or may not alter the hormones of the body and thus can contribute significantly to side effects, and some of them have direct contraindications or side effects that need to be considered because they'll prevent a woman from using them. So we talked a little bit about behavioral methods already when we were talking about hormone fertility awareness. So the fertility awareness-based methods or fertility monitoring-based methods actually have really good efficacy if they are used perfectly. So their efficacy rate is 95 to 99, but their typical use pattern is much lower. They're free for the most part. You may have to buy a thermometer or something, but there's no medication nor hormones or foreign bodies. They're not as reliable, especially in the teen years and during the during the times of hormonal transition. For example, after menopause, childbirth, or when discontinuing a birth control. There are several methods to this, and we discussed a couple. One is the standard days method or the calendar method, in which you avoid basically a large chunk of the cycle to prevent a pregnancy. Women will, with a cycle that lasts 26 to 32 days, basically avoid intercourse on days 18 through 19. That method's obviously quite inflexible because you can only really have sex between menses and day-night. Between menses and ovulation, and then day 19 to the onset of the cycle, so very few days overall. Other methods include cervical mucus monitoring, basal body temperature, and then a combined method which is called the symptothermal method or the Marquette method. I want to point out that the withdrawal method, so having the male partner withdraw before ejaculation, is actually really effective if it's done perfectly, but men don't do it very well. So that the effectiveness rate is only 78% compared to an efficacy of perfect use of 96%. Just anecdotally, or just interestingly, the myth about pre-ejaculate containing significant levels of sperm is actually not so much true, it turns out, and that this method really does actually work pretty well. Okay, so oral contraceptives, these so there's a lot of oral contraceptives. I'm not going to go through each one of them, but I do want to point out that the hormone combinations in each pill will affect how often they need to be taken and how perfectly they need to be taken. So for example, the estrogen-containing pills are a lot more forgiving than the progesterone-only pills. The progesterone-only pills need to be taken within 3 hours every day or they can wear off. However, the combined pill has a number of disadvantages and contraindications, so it's more likely to cause some side effects as well as some adverse events, and it also needs to be used very cautiously or not at all in women with certain cardiovascular risk factors or gallbladder disease, or breast cancers. The progesterone mini pill only lasts about 27 hours. That's probably the most important thing to remember about the pill. And so it's not as effective as the combined contraceptive because you have to take it within a 3-hour window every day in order to keep it working. Again, contraindications are there. You shouldn't use it if a patient has undiagnosed abnormal uterine bleeding because it can actually reduce the amount of bleeding, which is good, but you don't want to mask a problem. Again, for whatever reason, lupus is a contraindication as well. Vaginal ring is basically a non-oral, and it's not implantable either. It's a temporary method that is a ring inserted to the vaginal cavity for 21 days and then removed 7 days. This allows it to have many of the advantages and disadvantages and contraindications of the combined oral contraceptives, but the patient doesn't have to remember quite as much. So the perfect use rate of efficacy is actually a little bit higher. Typical use is pretty similar to oral contraceptives. A note about those rates for oral contraceptives, this 91 for the vaginal ring is probably more accurate as opposed to the 91% for combined contraceptives. A lot of the research on contraceptives did not separate progesterone-only users from combined users, and so because progesterone-only users have a higher fail rate, the combined oral contraceptive failure rate is probably unfairly high because it included some of those progesterone users. Contraceptive patch works very similarly to the combined oral contraceptive, except that it sticks on the skin. Leave it on for a week at a time, so you'll use 3 of them a month, and then you take off the patch for your period. Basically the same risks as the combined, except a higher risk of thromboembolism. Very effective, can cause skin irritation. The long-acting reversible contraceptives have not had good uptake in the United States, but they are actually tremendously effective, and they're a really good option for, especially for young adults who are responsible enough to use barrier methods for STI prevention. So it works, there's different ones. The copper one, IUD, is inserted into the uterus. It's often called the IUD because it doesn't have any medication, so intrauterine device. It inhibits fertilization and inflames the endometrium, and that prevents implantation. The nice thing about this one is it can work for up to 10 years. I believe it's only approved in the United States for 7 years, but we do believe they can work for up to 10 years. And there are some patients in whom it's not a good idea. For example, a history of pelvic inflammatory disease, pelvic cancers, abnormal uterine bleeding, because it can increase bleeding, and any anatomy that might make it hard to insert. The intrauterine systems are the ones, they're basically the same as an IUD, except they also contain progesterone supplements. The Mirena has a little bit more in it than the Skyla, and the Skyla is a little bit smaller, which probably, they sometimes say the Skyla is better for use in women who have not had children because it's not as large. I don't know that it really makes that much of a difference or that that's been studied. There is a risk of perforation or expulsion. Expulsion typically happens in the first 3 months, and it also typically happens in women with heavy bleeding. However, if you can get them to use one of these, that can actually help with bleeding. It may reduce bleeding and may improve dysmenorrhea. However, it can also make them worse, although that is less likely. Another LARC, or long-acting reversible, is the implanted device, which goes into the arm as a subdermal implant. It only contains progesterone. It can be used for older women. You can put it in immediately after delivery. Actually, you can put in the Mirena IUS and the Skyla IUS immediately after delivery as well. And then it can cause some side effects. Depo-Provera is a long-acting reversible. It lasts for about 12 weeks. Typical use is not as good in terms of efficacy, and that is because people forget to come back for their second shots. They have to be no more than 12 weeks and 5 days apart in order to be effective. There are some relative and absolute contraindications to this method, but similar to the IUS systems and the implant in the arm. You probably are pretty familiar with barrier methods. Some of these are combined together. So for example, spermicide is used with the sponge and the female diaphragm and cervical cap. So these are the different components of each one. Keep in mind though that these rates, these are the perfect use and typical, and that's for this perfect and typical for the male, perfect and typical for the female. Condoms are fairly effective as contraception. The only one of these, though, that does provide STI prevention is condoms and female condoms. Lastly, in terms of contraception, there is emergency contraception and the IUD the copper IUD is actually the most effective. It can be inserted within 5 days, and it keeps that sperm from fertilizing the egg and implanting. There are also some oral medications. One of them is over-the-counter, and it is a progesterone-only pill. Combined emergency contraceptive pills are given in higher amounts than would be used just for prevention. You can give your patients information and also a prescription for emergency contraception to prevent them from getting pregnant. Your job is to be part of the prevention mechanism and not just dealing with an unwanted pregnancy. Permanent sterilization is another option. There are several different ways of going about this. Male sterilization is typically safer and better tolerated, less costly, and has less recovery time. And it can be reversible, but it's not intended to be reversible. The longer it's been since it was reversed, the less likely you are to be able to have it reversed. Female sterilization can offer some non-reproductive health benefits. For example, patient has a lower risk of ovarian cancer and pelvic inflammatory disease after a tubal. You need to be careful that you're discussing the desire for permanent sterilization with patients, especially pregnant patients, because not all hospitals will perform sterilization procedures. So Mount Carmel will only perform them after an ethics committee consultation and only if there's an instance of potential morbidity or mortality to the female patient. So if a woman wants to have a postpartum sterilization, I would encourage her not to deliver in a Mount Carmel hospital unless there has already been an ethics consult and a certification of a concern for the woman's health related to continued fertility. Nurse practitioners in Ohio are not allowed to prescribe any drug or device to perform and induce an abortion. However, you are able and you should be responsible for helping patients locate where the procedure can be performed or provide advice for obtaining these services when indicated. There are some different medications. There are gestational age criteria for these medications. These two drugs can be used by nurse practitioners for other issues. So for example, you can use one of them for facilitation of a spontaneous abortion. So when a woman is miscarrying, you can help her to continue that process. A dilation and evacuation or surgical abortion is also an option for these patients, and you should, and that is more so after this date range. And then you should also always provide psychosocial support for families and patients. So a couple key things about preconception counseling. The major goal is to identify the social, biomedical, and behavioral risks that would impair a healthy pregnancy, and then address those risks so that a patient can have a healthy pregnancy, or to make sure that the patient is not going to accidentally have a pregnancy that is not what they want or what would be healthy for them. We do know that it's helpful in reducing preterm birth, low birth weight, unplanned pregnancy, poor outcomes, unintentional pregnancy, I said that twice, and narrow birth spacing. So there's a lot of components. Number one, we want to control chronic conditions for both the male and female partner. We want to make sure that immunizations are up to date. We want to check medications to make sure that there's nothing that could hurt a fetus or impair a pregnancy. We want to make sure that the patient has adequate nutrition and not excess nutrition. We want to review a family history and check for genetic risk factors. We can offer genetic screening if there's risk factors that are present. We want to discuss substance abuse and risky behavior, for example, alcohol, tobacco, caffeine, or illegal drug use. We want to make sure the patient doesn't have any occupational exposure or safety concerns. So this is my 2 cents, and if you remember nothing else from this lecture, I want you to remember this. I want you to be talking about this with your patients because this is the big point. Everybody should have a plan for whether or not they are having kids or not having kids right now, or whether or not they plan to eventually, maybe in the future, or not at all. Women who are considering pregnancy need to take a prenatal vitamin, and that needs to include folic acid. If a couple's lifestyle or an individual's lifestyle is not consistent with a healthy pregnancy, then you as the provider need to help that woman or couple make an effort to either prevent a pregnancy or adjust their lifestyle to have a healthy pregnancy. Toxins and substance abuse should be avoided. Men and women need to know their family history, and everybody needs to be at a healthy weight so that if they want to or are pregnant, that they're in the best situation possible. Okay, I'm not going to go over infertility in this, but I will tell you, I'm not going to go through it. I do want you to read through this as far as what are the causes of infertility. Age is pretty much the biggest reason that people are infertile. It affects about 1.5 million women, and 6.7 women are affected by an impaired ability to get pregnant and then carry the fetus to term. So that's called fecundity. About 12% of women of childbearing age eventually will have an infertility workup. So we're going to go through, you can go through this on your own time, but what does infertility mean? When should a woman have a fertility workup? And then I want you to just be aware of your responsibilities as the primary care provider. You need to do an H&P on the female patient. You need to do an H&P on the male patient. You need to look for reasons that they may have trouble conceiving. You need to then do some diagnostic studies to get started. You need to check hormone levels. You can order a semen analysis for a male patient. If anything comes back abnormal, you should refer them on to the specialist that can help them. Usually this is a reproductive endocrinologist. Some gynecologists do reproductive gynecology and endocrinology as well. And real quick, if there's a clear diagnosis, you can certainly initiate treatment. So if they have PCOS, if they have hypothyroidism, if they're obese, you can certainly get them on the right path while you're waiting for that referral. There are some couples who should definitely be referred even before they are ready to have kids, but to discuss options. And this includes same-sex couples, single people who would like to parent, a couple that's missing reproductive organs, whether based on a genetic disorder or surgery or a trauma of some kind, and then anybody who has had multiple miscarriages or a history of fetal demise. So this wraps up our presentation on fertility and preconception counseling and contraception. Please make sure that you review all the slides and the notes. If you have any questions, again, just you can post to the 24-hour discussion board or write them down and bring them to class. These are our references, and I hope that this lecture was beneficial to you.